This podcast is produced by Outcomes Rocket, your healthcare exclusive digital marketing agency. Outcomes Rocket exists to help healthcare organizations like yours to maximize their impact and accelerate growth. Visit outcomesrocket.com or text us at 312-224-9945.
Welcome to Expanding Access, a podcast by Behavioral Health Tech, where we explore the cutting edge of mental health, substance use, and autism and IDD care. Each episode features insightful conversations with industry leaders who are driving real change through technology and innovation. Whether you're a provider, payer, or just passionate about expanding access to behavioral health care, you won't want to miss these stories. Let's dive in. Hello, everyone. I'm Solome Tibabu. I'm the host of the Expanding Access podcast, where we're covering all things expanding access to mental health, addiction, IDD services through technology, health equity, and innovation, and covering stories of lived experience and industry professionals. So, of course, I'm so excited to have longtime friend and BHT OG, David Ricupero. Thank you so much for joining us. So excited to jump right in. Why don't we get started with, tell us a little bit about your background, what you do, and how'd you get into this space?
Sure. Thanks for having me. Behavioral tech has been great to see grow, I'll say. I remember, 5 years ago, I think it was, the text message in the middle of the night of, hey, do you want to start a conference? And here I'm getting interviewed at it. And I think this will be, what is this, the 5th year for now in coming November?
6th total, third in person.
Gosh. Third in person, that's right. And I haven't missed one, for the record. My name's David Ricupero. I've spent the past 8 years in the behavioral health space, so primarily focused on business development for the past 3.5 years. Right now, I work for Affect Therapeutics. So we're actually a CARF-accredited virtual provider for substance use disorder treatment. So we focus on Medicaid populations. About 90% of our members are Medicaid, though we do serve some commercial and Medicare members as well. So to kind of give you a brief overview of what Affect does is we treat opioid use disorder, alcohol use disorder, stimulant, cannabis. Kind of like our secret sauce is we use contingency management. So that means we provide financial incentives for engaging in recovery-focused behaviors. So if a member attends a counseling appointment, if they get a negative drug screen, right, they get a financial reward for that. And the reason why we do that is contingency management is actually the gold standard for treating stimulant use disorder. That's really how we got our start. And since then, we've expanded into other conditions, including programs that incorporate medication-assisted treatment. So really what it looks like for a member to go through our program, there's an intake, there's monthly medical visits with a physician, some medication management and co-occurring disorder management. They do weekly counseling sessions, twice weekly group counseling, and ongoing support from our member advocate team. So that's like a peer support. I call it the DoorDash for recovery, right? Anybody can reach out to these folks and they'll help link them to services. And I'll close out here because a lot of folks always ask me, well, then how do they get the financial incentives, right? So they're actually distributed through the Affect mobile app and they're sent to each member also gets a smart debit card. So that member sees the, hey, look, I attended this appointment or I have this negative drug screen. The money, the financial reward there instantaneously hits the app that gets linked to the smart debit card. And then these individuals are out there where they live, spending this on food, gas, whatever it may be. So that's Affect. And then I guess I'll close out here with it. I'm also the co-instructor for the out-of-pocket How to Contract with Payors course. So it's an online course. It's through outofpocket.health. My goal was to demystify the payer contracting experience because when I entered in here, I had no idea what's going on. I still feel like I have no idea. But the main goal was I don't see payer contracting as being too complex. I just see it as it being like kind of hidden on what to do. So the main goal was to demystify that and give you the essentials to contracting with payers, whether it's things about strategy, how to present, how to negotiate, deal closure. And then by the end of it, you have like a playbook, if you will, how to navigate future contracting endeavors.
Really great. And you've not only been a business development leader for a variety of behavioral health companies, but such a great advocate for the topic and advisor to so many, including us. And so really great to see that you actually put together the course. It's a wonderful resource. We'll include the link for everybody. But let's hear a little bit about the secret sauce that you share. Why don't we get started with, let's say I am a behavioral health provider. How do I get started with contracting with a payer?
Sure. I mean, the contracting process, right, with payers typically starts the same way for everyone. You visit the payer's website, you fill out a form, you already download a PDF and fill out that form. You submit it in, to request a contract. During this process, some plans will ask for supporting documents like your certificate of insurance, your state license, your Medicaid ID, a provider roster. And then once submitted, you usually have to wait 30 to 60 days to hear back whether or not they want to move forward with you. If they do, great. You then submit typically credentialing materials. And from there, it takes another 30, let's say to 90 days to receive an actual contract and effective date. Now, that's the standard path, right? That kind of everyone goes through. Most providers aren't looking for a standard contract, right? They want better rates than the traditional fee schedule. And, that's enhanced rates, pay per performance incentives, bundle payment, shared savings. And that contracting process is different. And this requires more conversations with folks at the plan, right? This isn't just an application you fill out and boom, you got a value-based contract. But these are conversations you have, and that could be anyone that works in contracting, network, clinical, or C-suite. You really have to hustle to find these folks. So those are really the two most common contracting options, right? Option one, you apply on the site and get a fee-for-service contract. Option two, you need to find someone at the plan to negotiate a value-based contract.
So fair to say that the value-based contracts, which we'll get into a little more, require a little more partnership and trust building before we're going to dive right into that. I guess, would you say a fee-for-service contract is kind of a given? You just apply and you're in then for those?
For the most part, some payers have closed networks because let's say they feel they have enough providers. But for the most part, there's so much demand for behavioral health services. Payers are always willing to accept new providers. I've been in the position where sometimes, a payer does deny your application because let's say they have a closed network or they feel like they have enough providers. I would recommend just to accept that. Try to find out the why behind they don't want to accept you. Maybe it's enough capacity, right? Dig in and try to find out. Maybe they're lacking providers in other areas. So go on their website, dig around. Maybe they lack access in rural areas or treating pregnant members. Offer to target and just kind of treat those members for a set period of time. And after that, you can evaluate outcomes or your progress. But the main goal is just try to get in. And once you're in and you do good work, you're good for the most part.
And for the newbies listening in, what's a closed network?
A closed network is essentially a payer feels like they have sufficient network adequacy to where they don't need to add any more providers. So a use case would be like this, like I'm a payer in Arizona. Let's say I have my member population. I'll give you an example because math is hard. I have 100 members and typically only one provider can treat one member. So I basically need 100 providers then to treat my 100 members. And once they have that kind of looks like, oh, they have network adequacy, right? I have enough providers to treat all my members. And so when they do have that, they kind of want to stay there because additional complexity such as, okay, if I have to add new providers to the market, I have to do more credentialing, I have to do more licensing, maybe just take more admin work. Also, if I'm just adding in providers whenever I want, maybe I might not be able to control quality as well. So I understand the value to a closed network for health plans because it just really helps them control quality more and kind of like less administrative work. But I would say, in my experience, maybe 5 to 10% of the time you run into that, but there's always reasons you can present of why they should let you in and the value you provide.
Super helpful. So, of course, behavioral health tech, we talk a lot about making that transition into value-based contracts. And I'd like to ask you how one would do that, but maybe you could define a little, what are the different characteristics of a value-based contract that a provider should expect?
Yeah, absolutely. I like to think of value-based contracts on like a spectrum, right? The left to the right, I'll explain the contracts, but from the left to the right is also how much risk you're taking and also contract complexity. So on the very far left, right, you have fee for service, right? You're not really taking risk, not a complex contract. You send in the code, you get paid. And on the very far right of it is capitation, right? You're basically assuming the risk of a population that the health plan has. There's a lot of risk there, and there's also a lot of complexity. So think of it like that. So to fill it in, on the far left, you've got fee for service. And then the next step up from there is pay for performance. So where, hey, if you lower something, X%, you get $1, whatever it may be, or pay for reporting, right? Every time you report that you made a referral into this, you get $1. And then the next step from there is like a bundle or case rate. They're used interchangeably, but this is essentially, hey, a payer is going to pay you a lump sum every month for a group of services. So let's say you have an eating disorder program, and in that program, generally you do 4 therapy sessions a year, or excuse me, 4 therapy sessions a month, 1 medical appointment, whatever it may be. You basically take all those encounters and the costs associated with those encounters, you wrap them up, and that's that case rate or bundle rate. And then the next step is the shared savings. And shared savings really is defined. Think of it as saying, hey, look, I think I can save money by providing good outcomes for your population, whether that's, hey, I can reduce ED costs, emergency department costs, or inpatient costs. And because of that, I want to be rewarded for it. So a health plan will say, okay, great. Let's say the average emergency department cost of each one of my members per year is $10,000. If you, for example, as a provider, treat that member and the average emergency department cost for that year is $9,000, so it went from $10,000 to $9,000, there's a $1,000 margin in there. You're basically saying, hey, I want to participate in that $1,000 savings that I provided. Why don't you give me 50% of those? So 50% of that $1,000 is $500. So that's shared savings. And then you can also build risk into that. So, hey, if we save you money, we get paid a bonus for that. But if our cost, that emergency department cost I just explained, it came in at $9,000, so we're saving the plan money. But if we came in at $11,000, we've actually cost the plan another $1,000. So that would be called downside risk, or you would actually be on the hook on that. And then, like I said in the beginning, the far right of this is capitation, which is, full risk. You're managing a population, and it doesn't necessarily have to only go from left to right. You can mix those. You might have a bundle rate with pay for performance measures, or a shared savings with pay for performance measures. But that's kind of like the contract buffet you can pull from and you can kind of choose from, but it always depends kind of on what are the payers most comfortable with.
Okay, so needless to say, we don't want to be flippant jumping into value-based contracts. But now, let's say I've had quite a few fee-for-service contracts under my belt as a provider. What do I need to do to make that transition into my first value-based care contract?
Yeah, great question. Ask that question every day to myself. From the very basics, to help everyone out. Number one is, getting someone at the payer to discuss the option with you, right? Which is a challenge, right? So that's tough because you're starting from square one, right? Who do you email? How long would the process take? Really, the most effective process I recommend as far as kind of breaking into a payer and having these conversations is actually doing 2 things in parallel. Apply to join their network through the traditional way, right? The website, like I explained, and hustle to find folks you think can assist at the health plan with the value-based contracting. So email, call, do whatever you need to do to get them on a call. And I kind of call this parallel process. I actually call this in the course applications versus conversations, right? You're basically doing both. And the value of doing the traditional route, even though you're shooting for a value-based contract, is while you're searching for folks to actually have these conversations, you're on LinkedIn, whatever it may be, the traditional route will actually help make the conversations part easier. So for example, if you're starting from square one, you need to hustle, right, to find someone to talk to. When you apply through the traditional route, you're going to be introduced to a provider rep or a contract negotiator. You can really lean on these people for contacts at the company you need to reach out to and discuss the value-based contracts with. In fact, they might be the right person you need to talk to first anyway. So I've seen payers do value-based contracts at the C-suite level and other folks that have done them just, at the contractor level, right? Or the first person you're introduced to. A case for that is a lot of payers now might have these boilerplate, already built value-based contracts for your provider type that you can opt into. You don't know. So that's why I say start on both angles. The other benefit of applying the traditional way is it helps with your messaging and your conversation. So when you send an email to someone that, hey, I'd like to discuss value-based contracting with you, saying you're a provider that isn't even contracted is hard for them to prioritize, right? With all the work they have to do. But by saying that, hey, look, you've applied, you're going through the process, you're getting ready to get contracted, it shows that you have skin in the game and you're more likely to entertain a call or respond to your email. And the last thing is, let's say you only spend your time trying to have conversations, right, with someone. You don't want to go the traditional route. You're special. You don't want to talk to someone at the health plan about value-based contracting. Well, when you finally get on the phone and let's say they do say yes, they want to do a value-based contract with you, guess what you now have to do. You have to go through the traditional application process because you still need to apply, present your license, your insurance, and everything. And the last thing is, let's say you only spend your time trying to have conversations with someone at the plan, right? You're special. You really want to just have that high level conversation. When you finally do get on the phone and they say yes, and they want to do a value-based contract with you, well, guess what? You still have to go through the traditional application process. You're still going to have to submit your licensing information, your certificate of insurance. So even if you get all the way through a fee-for-service contracting process and they send you a contract as well, you don't have to sign it. So don't feel like you're going to be going through this traditional fee-for-service process and you're going to be stuck that way, right? You can always kind of sit on that contract until you're ready. So the key takeaway here is I say, don't wait, submit the application through the traditional way and also start the conversations at the same time. And doing both is really how you can move the process forward and give you I would say, the most likely way to get connected and get things going.
Great. Okay. So let's say I am on top of my application, got that submitted, but really want to break it down now. Let's say I secure the phone call with the right person to have that initial conversation for the value-based contract. What am I saying exactly?
Sure. You can find sanctions. So, hey, look, if a health plan ranks below a certain quality measure, right, they can get fined. Also, you can look at quality withhold. So some states will, let's say, hold 2% of the total capitation amount that they're giving to these MCOs, and they have to earn it back through quality measures. So really kind of find out where the money is. So that's kind of like the outline of what's important to them. And the other thing is really qualifying, right? Ask if they've ever done any value-based programs for your provider type in the past, right? Are there any currently built? Some payers have programs you can join, right? That's the easiest way. Ask if they currently do any form of value-based contract for your provider type. How is it structured? Is it pay for performance, shared savings? As a potential new provider to their network, you're most likely going to have to work within their existing frameworks, right? You haven't really proven yourself yet, so you're going to have to do that. But if they say no, hey, look, we don't have any value-based contracts for your provider type, they don't have anything existing, getting a contract is going to be tough, right? A payer doesn't want to invest time creating a complex contracting structure with a net new provider that hasn't proved that they can recruit or treat their members. And this is why I emphasize trying to work within their framework. What do they have going on? If it works for you, copy paste that for your contract. For the majority of net new providers, I should say this, for the majority of net new providers that a payer is engaging with, if they don't have any value-based contracts for your provider type, it's going to be hard for them or willing to make a value-based contract, for you. Because like I said, you're a net new provider. It's going to be very tough. Typically, for the majority of net new providers like you, payers want you to do, let's say, a year's worth of fee-for-service contract, prove you can recruit, treat their members, send in claims correctly, deliver good outcomes, right? And then after that, they'll discuss value-based contracting with you. This sounds good, but you want to make sure you don't get caught in what I call payer purgatory. So payer purgatory, it's the state where you spent time proving that you can treat folks, operating well administratively, your outcomes are good, and then you're still stuck with a fee-for-service contract 12 months down the line when they said, hey, look, we'll reevaluate in 12 months. And that's when we can move you into a more friendly contract environment. And that's not necessarily them misleading you, right? Sometimes payer priorities change. They no longer can do them. So it can be anything, but essentially, you're stuck with the rates in this contract structure you don't want. And what I have found successful is to hedge this risk, get the payer to define the milestones you need to hit. How many members do you need to treat over how many months, right? What outcomes? And then what's the contract rates? If you do, what would the contract look like? Okay, if you do achieve this. This sounds simple, but it's very hard because for the most part, payers are not committal about this because their job is to see what things will look like down the road, right? They're very risk averse, but if they don't have any current value-based contract with your provider type, to hedge this risk, get the payer to define the milestones you need to hit, right? How many members, for how long do you need to treat, what outcomes? So if you do everything right, what does the contract look like 12 months down the road? This sounds easy, but it's hard because a lot of these payers might not have that type of information down the road, right? But also if they've never done a value-based contract with you or a value-based contract with your type of provider, they don't even have one created. So that requires a little work that you have to do on your end and also based on your risk tolerance.
Okay, super helpful information, David. Now, let's say we had this successful conversation with the plan about a strategy to move forward with a value-based contract. We've even had a year or two under our belt with fee-for-service. They can see some traction already. Now, what is step one?
Sure. As I said before, if you're looking for speed and they have an existing contract or similar contract with a different provider type, copy that. The unit economics work, get started. Later, you can adjust terms after you've built some trust. But the main goal here is momentum. Get started. Remember, the more complex you make a contract, the more people get involved, and those are more potential no's. Like I said, just get going. But let's say they don't have a value-based contract for your provider type, but they want to do one for you. How do you know what the contract will look like? And really what I think in this scenario is the contract you do is the one they're most comfortable with. So just to make sure the contract you do is the one they're most comfortable with. So these contracts take work. It takes effort for payers to measure. If you really save money for them, the more complex the contract, again, the more work involved and easy for them to kick a can down the road. This is why I say try to find what quality measure or data point they do know really well and are precise about and base the contract off of that. So this removes the fear that they will do something wrong and the contract will be a bust for them. So de-risk the decision by working within their precision, if you will. So that means, hey, maybe I want a shared savings arrangement. I want it because I predict it'll make me, let me earn the most amount of money. So let's say $100 per member per month. If I do a shared savings contract, that's what I feel like I'll be able to earn per member per month. The challenge is shared savings contracts are incredibly complex to execute, especially when you're a new provider or working with a payer that hasn't implemented this kind of model for your provider type. Also, if the payer's never done any shared savings contract for your provider type, then you're in a really tough spot. And so this is why I recommend zoom out and look at the problem through a more practical lens. Like, is there a simpler way to reach the same financial outcome, that $100 per member per month that you want to earn, by anchoring it to a data point the payer already knows and trusts really well? So for example, maybe the payer knows that when they look across their SMI, severe mental illness population, 25% of them are hospitalized at least once per year, right? That's a metric they're tracking and they feel confident about. From there, you can propose a structure that, hey, look, if I keep my inpatient admission rate under 25%, I receive a defined payment or a bonus, right? Enhanced rate, whatever it may be, but it basically levels you up to that $100 per member per month. So if you reach below that 25%, let's say at the end of the year, you get $100, or maybe you break it down to where it's a percentage of the fee schedule that gets increased, that is baked in, that gets you to the $100. So you're still getting that $100 at the end of the day, but you're just getting it through different paths. Sure, this isn't technically shared savings, but it achieves a similar outcome, right? You're aligning the financial incentives to reduce utilization. And at the end of the day, right, it's much easier for the payer to implement, because as you execute on that simpler contract and demonstrate performance and you build that trust, that opens the door to more sophisticated models down the line, right? You might evolve to a full shared savings later. Also, as you build trust, you'll get better referrals, access to, let's say, new member populations, or maybe you get introductions to other sister plans in other markets, right? These health plans are big. They cross a lot of different geographies. So I would say the real key takeaway from here is start with something the payer already understands and can operationalize, deliver result, and then use that foundation to move into more, let's say, advanced contracts, or move into, let's say, just contracts that pay you more money.
Anything to de-risk the situation. They'll add more comfort and better outcomes, of course. Really great. So you talked about more advanced situations, even more than where we are at this point in our value-based care journey. Of course, I have to ask, how do you take the next step to that, into an even more advanced value-based care model?
Sure. So this is basically, hey, great, you're contracted. Let's say you're getting that $100 average per member per month through some type of bonus or whatnot. Now you want to, again, take the next step, get more risk so you can earn more money. I think to really make this clear, let me define a shared savings. So, and then I can get into it, because I know this helps me. It always helped me. I know we talk about things like the obvious, and maybe perhaps some of the listeners might not clearly understand what it is. So I think this might help. So the idea behind like a shared savings contract is if you deliver care more efficiently, let's say fewer emergency room visits, hospitalizations, and if that reduces the total cost of care, right, the health plan agrees to give you a percentage of those savings. But also, typically in shared savings contract, there's something called also a quality gate. So you only get the share of those shared savings if you hit certain quality targets. So that's a health plan's way of making sure you're not cutting corners just like to save money. So one common quality gate in the behavioral health space would be the HEDIS measure, IET, initiation engagement in substance use disorder treatment. So more or less someone gets discharged from the hospital or some inpatient settings because of an SUD diagnosis. How quickly can you get them into care? The data shows the quicker you get people into care, the better they're going to be. So that would be an example of quality gate. But really, if you want to move into a complex arrangement like the shared savings model or anything a bit more complex, I think the key questions you need to ask are, what's the benchmark? How will the total cost of care baseline be calculated, right? Is it going to be prior years? Is it going to be on a cohort basis? This all has different implications to the math, right? Is it going to be risk adjusted for acuity age diagnosis? And that will really inform you to see how much money there is there to potentially save, right? So also, what's the quality gate? Are they going to want to do HEDIS measures? Which ones exactly? What type of threshold is there going to be to meet those savings? So sure, let's say you have to reach the average quality measure is 20%. You need to be just over 20%. You need to be 25% plus, right? Figure that out. If you also, will you get paid only if you hit those quality measures? Could you potentially get paid partial of those shared savings if you only hit some of them? And also, how is shared savings going to be calculated, right? Is there a minimum savings rate before savings begins? Like, let's say the first 5% of savings, right? They just hedge that saying maybe that's just cost variability. You're not going to get the first 5% of savings, but you will get, let's say, the percent of savings after that. So, and also are the savings going to be shared equally, right? It's going to be 50-50, is going to be a tiered model. These are key questions. Also, I would talk about the attribution model. Are members going to be assigned to you? Literally, is it going to be are you get a list of members? Does a member attribute to you after you have a certain amount of encounters with them? And also the reconciliation timeline. Like, when will we know if you met the cost of quality targets? Are they going to be providing you internal data throughout the year so you can see, okay, I need to, let's say, turn the dial and improve these things? Also, data is important. So like, hey, if you're going to have to hit certain type of quality measures, are we going to get a feed or are we going to get a member roster every day, every week, so we can follow up with these people? Because you want to have, workflows in place. Make sure you hit those quality measures because you're putting in all that work to hit the quality measure and then eventually, get the savings. And then how much risk is involved? Is downside risk required, right? Are you going to have to owe money back if costs go over that benchmark? Lastly, I'll finish up with this is, how are outliers handled? We all understand that the top 20% of people are responsible for 80% of the cost or whatever it may be. I always recommend, can we carve out the top 3 to 5% of high cost members? Because, you might do fantastic across the whole population, but there are 3 people who fell off a cliff, right? and was in the hospital for 9 months and that threw everything off. So these are all little things that you'll discuss with the health plan. And also, I always recommend they're things you come out the gate before they give you their thoughts on it. I would say, hey, look, here's a good structure that we would like for this. And typically it'll speed up things because health plans are busy. And if you come at them with a pretty good structured contract that kind of checks all their boxes as far as the things they're thinking of, and the only thing they'll have to do inside those boxes, maybe tweak a couple things. Hey, look, maybe the quality measure is this instead, or maybe the shared savings is 2 or 3% more or less than that. It just gets you going. So when it comes to contracting complexity, those are really the key questions I would ask a payer. And then once you have that information, you should be good to go.
Just like that. Good to go. You make it sound so easy.
Yeah. No, yeah, it's definitely a challenge, but it's fun. There's just a bunch of key questions you have to ask. These are some of them you'll ask. And I think once you get these answers, really the answers will direct you to the next steps you have to take. Like I always said, like why I started the course, the goal was to demystify the contracting experience. It's not a linear experience. You don't just start from A and end up to Z in this really clear way. It's often back and forth, but if you ask the right questions and get those answers, it'll help you lead you down the correct path.
And for folks listening, as you can tell here, this is an indication of how in-depth and detailed the course is. So I highly recommend it. And of course, we'll include a link for everybody in the show notes. But David, I really thank you so much for sharing your expertise with us. This was so helpful just from start to finish, that whole journey of behavioral health provider contracting with a payer. And for those who like what you heard today, we have tons of content about value-based care contracting, payer-provider partnerships. And in fact, that's the name of several of our tracks and programs at the 2025 Behavioral Health Tech Conference. So of course, save the date, November 11th through 13th, this fall in San Diego. Excited to see all of you there, including David. So thank you so much.
Yeah, thank you.
Thanks for tuning in to Expanding Access. We hope you're feeling inspired by today's discussion. If you've enjoyed the episode, subscribe and share it with your network. For more content and opportunities to get involved in transforming care, visit behavioralhealthtech.com. Until next time, let's keep pushing boundaries and expanding access together.
This podcast is produced by Outcomes Rocket, your healthcare exclusive digital marketing agency. Outcomes Rocket exists to help healthcare organizations like yours to maximize their impact and accelerate growth. Visit outcomesrocket.com or text us at 312-224-9945.